Thank you so much. Thank you so much, Arun. Very, very appreciated. That's a very kind introduction on your part. I'm delighted to be here among you all to share my program of research related to ventilator weaning and extubation in patients with primary brain injury. The goal of this talk will be mainly to review recent evidence and ongoing uncertainties, of which there are many. As Arun mentioned, I do get funding from the CIHR for some of the projects that I'm going to discuss in this talk, and I'm also funded by the Clinician Scientist Training Program at the University of Toronto. So the objectives of this presentation are threefold. We'll start by providing some context and reviewing data on prognostic factors for extubation outcome in patients with brain injury. And the focus is mainly going to be on landmark studies or the literature-defining studies, so to speak, in this domain. And across those studies, I'm going to hope to highlight key themes across certain prognostic factors, mainly to build a narrative around what factors might be important and what factors we may want to question or think a little bit about. Next, we're going to segue into recent efforts from our working group to improve some extubation decision-making in brain-injured patients. And then where it's pertinent, I'm going to be describing statistical and epidemiologic methods that can help us improve the interpretation of studies in this clinical and research domain. So that stats and epidemiologic piece will be inserted here and there where I think it's relevant to the study design and the interpretation of studies. And if there are questions about any of these aspects, I'm happy to take them as we go along or at the end of the talk. So the context for this talk, I think, is nicely set by this paper by Chiara Roba and Robert Stevens. This was published in Intensive Care Medicine in 2020 and really set a research agenda for mechanical ventilation in patients with acute brain injury, and also talked about various domains that are relevant to their care, including extubation and weaning related decisions. So there were 6 or 7 domains that these authors looked at, and within each domain, they appointed content experts, performed systematic reviews to answer questions that were pertinent to that domain. And then there was a Delphi process to rate the strength of recommendation according to the quality of the literature and expert opinion. So I'm going to be looking through here the extubation and weaning related domains, and they ask some pertinent questions that clinicians and interdisciplinary experts often ask themselves when they're getting ready to wean or liberate a brain injured patient from invasive ventilation. Namely, what factors should we consider? To what extent should airway protective reflexes and the patient's level of consciousness guide this decision? And as you can see, there are strong recommendations for certain things that many of us would probably agree with. We should probably pay attention to the airway protective reflexes, should probably pay attention to the level of consciousness. And there was moderate evidence in favor of these. There was also this recognition that we should account for factors that are pertinent to patients without brain injury. Again, this is a subpopulation within an overall critically ill patient population. And so we should account for, again, some of those factors. And then they also recommended that cough, gag, and swallow should be importantly considered. There was a strong recommendation, but I'll draw your attention to the fact that there was no evidence in this domain. They did not perform a systematic review. And as indicated, they were also unable to provide recommendations regarding specific GCS thresholds to guide the decision to extubate. Again, there was no evidence because they did not perform a systematic review for that specific prognostic factor. So some of these data derive from several landmark studies, which I will review chronologically now. Beginning with the study by Kaplan and colleagues in the year 2000, this was really a landmark study, implications of extubation delay in brain-injured patients meeting standard weaning criteria. This was a single-center prospective study of 136 patients done out of Seattle, Washington. And their objective was to compare outcomes between brain-injured patients who had been extubated promptly versus those who had been extubated with a delay. They identified prompt extubation as removal of the endotracheal tube within 48 hours of passing weaning readiness tests, and extubation delay was defined as extubation after that 48-hour time point. Between these two groups, they looked at the incidence of pneumonia, ICU length of stay, hospital length of stay, and hospital costs. So the first thing you'll see here is that of their 136 patients, 73%, which works out to 99 patients, were extubated without a delay. So the endotracheal tube had been removed within 48 hours of passing weaning readiness tests. And then in the remainder, which accounted for 27% of patients, extubation occurred with a delay. And when we look at the delayed extubation column, the primary reason why clinicians were holding up extubation was low Glasgow coma score. And that's somewhat apparent in this table 5 from the author's manuscript, where you can see that among the delayed cohort, the GCS is significantly lower than in the non-delayed cohort on the day of readiness. So this is the day they pass their weaning readiness test. And it remains low and significantly lower on the day that extubation was actually performed. You can see both these p-values are significant. What's interesting to me actually is not the horizontal comparison, but the vertical comparison, wherein you can see that the GCS is not changing all that much between readiness day and extubation day. And the authors in their results actually looked at the proportion of patients in whom GCS was lower or the same between these 2 days, and found that in 42% of cases, so just shy of half of cases, the GCS was actually worse or the same as it had been on extubation readiness day. So trajectories are important to keep in mind, and it was nice to see the quantification of those trajectories in this paper. They also looked at the subgroup of patients that were comatose as operationalized by a Glasgow coma score of less than or equal to 8, and they found that 78% versus 31% fell into these categories between delay and no delay respectively, and this was significant, and that difference remained significant on extubation day. They also looked at patients who were severely comatose, defined as in their paper GCS of less than or equal to 4, and found that surprisingly 90%, 90, of those patients were actually able to be extubated successfully, and of those who were GCS less than or equal to 8, the proportion of successful extubation was 80%. So a lot of these comatose patients, as defined in their study, were actually still being successfully extubated. And then to go back to their outcomes, they looked at the no delay versus delay group and found for these 4 outcomes, pneumonia, intensive care length of stay, hospital length of stay, and cost, all of the outcomes were substantially worse in the extubation delay column. This paper was published in 2000, and these are results in United States dollars. And you can see that even so, there's a substantial difference in costs between these 2 subsets of the overall population. So the interpretation, at least for me, is that low GCS remains an important cause of delayed extubation. We see this theme repeated constantly through the literature, including in much more recent studies, whereas delaying extubation is associated with worse outcomes. And again, this is a theme that's borne out repeatedly, not just in brain injured patients, but other cohorts as well. And then another important takeaway, as mentioned by the authors themselves, is that waiting for the Glasgow coma score to improve in patients where extubation is withheld for this specific reason may not be a productive strategy, because they showed that about half or slightly shy of half of patients were actually not recovering or improving their GCS compared to where they started. So that's study 1, and we'll pivot now to this randomized clinical trial by Neman and colleagues published in the following year in the Blue Journal. They did an RCT of predictors of successful extubation in neurosurgical patients, wherein they randomized patients to an intervention arm, which consisted of daily screens to undergo weaning readiness tests, which in this case was almost the equivalent of a spontaneous breathing trial. And then if the patient passed the eligibility criteria to undergo the SBT, they followed it up with an SBT. And then they would communicate those results to the attending physician that was taking care of the patient, and extubation was left to the discretion of the clinician. So all of these interventions happened within the treatment arm, and the control arm was usual care. However, clinicians approached extubation decisions, they were encouraged to continue maintaining that approach. And then between these 2 arms, they looked at the duration of ventilation, ICU length of stay, and time to successful extubation. So the results here are also quite interesting in the sense that out of 201 patients who received who underwent a daily screen, 99% of them received an SBT. So, and the reason this is higher than the number of patients is because multiple patients are being screened more than once. So that's why this denominator is not 100. So the takeaway from this first part is that we're quite good at screening patients and performing the spontaneous breathing trial once eligibility is identified. Interestingly, though, only a quarter of patients who passed the SPT were extubated, and the primary reason given in this study was neurosurgeons' concern about level of consciousness, which held up 84% of extubation attempts. I'm not saying this is necessarily for bad reasons. There are very, very pertinent and important reasons why extubation should not occur on the day that Weaning readiness tests are passed, but this proportion is certainly very high. And then extubation failure occurred in 38% of patients. This was defined as reintubation. You have to dig through the text a little bit, but it seems that it was reintubation at any point in the intensive care unit. And there was no difference between the intervention and control groups on any of these outcomes. And in this study, contrasting to the previous one, the strongest predictors of successful extubation were Glasgow Coma Score on extubation day and the PF ratio. So this is essentially a proportion of successful extubations per each ordinal rank of the Glasgow Coma Score. And in their multivariable analyses, they found that each 1-point increase in the Glasgow Coma Score was associated with a 1.2-fold increase in odds of successful extubation. And the trend, you can convince yourselves, is monotonically in the positive direction as GCS improves. They then looked at a receiver operator characteristic of the Glasgow Coma Score and found that the best predictive threshold to predict successful extubation was a GCS of greater than or equal to 8, albeit with an area under the curve of only about 0.68. So the really important caveat from this study is that 22 out of 44 patients who failed extubation were actually never reintubated because they had limitations in care in place. And all of those patients, so 100% of those 22, ended up dying. So one of the criticisms that's emerged from this study more recently is that the association between GCS and extubation outcome is probably confounded, because if the mortality rate here is 100%, these patients were probably also sicker on extubation day. And it's possible that GCS, which was probably lower, was simply an epiphenomenon or a bystander to higher illness severity overall. These are speculations that have been made kind of retrospectively, but I think there is probably some merit to those, mainly because some of the findings of this study are different or in the opposite direction from some more recent studies that look at GCS. One of those studies is this third study by Godad and colleagues. This was a really nice single center observational study of 140 patients with acute brain injury. It was done out of a single center in France. And the objective here was to develop a clinical score predicting extubation failure, which these authors operationalized as the need for reintubation or non-invasive respiratory support within 48 hours after the extubation attempt. So it wasn't just reintubations that were classifying as extubation failure. It was also the need for example, high flow nasal oxygen or BiPAP in the post-extubation setting. So the aim here again was to develop a clinical score predicting this outcome of interest. They used a lasso procedure to identify potentially prognostically important variables, and they entered those variables into a model and performed cross-validation within their single center data set and identified the following variables. So airway management variables seem to be very important in their model. That is to say the presence of cough, swallow, and gag reflex. And this additional item, the coma recovery score, revised visual item, was also very important. They looked at this as a surrogate for level of consciousness. I will also mention that extubation failure, according to their definition, happened in about a quarter of patients. The receiver operator characteristic is shown here for their model with an area under the curve of 0.82, so pretty good overall at predicting the outcome of interest. As a reader of this paper, what was very interesting to me was actually information they had put in their supplement. They looked at the total Glasgow Coma Score, which in intubated patients, they quantified as the sum of the visual component and the motor component. They left out the verbal component, which is actually different from how the ENIO study authors, which is a study I'll share with you in a few slides, they operationalized it slightly differently. But regardless, the total Glasgow Coma Score as the sum of these two components between GCS levels of 7 to 10 was leading to pretty comparable rates of extubation failure, as you can see here. And then even when we get down to GCS levels of 5 or so, where some of us may have pause in extubating a patient, rates were pretty comparable. I will admit, of course, that there were spikes here at lower GCS levels of 4 to 6. Very hard to put too much stock in this data because it is, again, single center. These are very, very small subgroups of patients. Again, only 140 patients overall. But I think qualitatively is quite interesting to see this trend that GCS, even at levels around as low as 5 or 7, may lead to comparable rates of extubation failure with patients who have much higher GCS. They then looked at the extubation outcome as a function of the number of airway protective factors, which were these 3 here. So we're looking at cough, swallow, and gag. And they quantified the proportion of successful extubations depending on the number of airway factors this patient had intact. So you can see that if a patient had 2 or 3 of those airway protective factors intact, extubation success happened in 90% of patients. And on the contrary, if none of these protective factors were intact or only one was intact, extubation success happened in only 10% of patients. So very, very illustrative data. They then looked at airway protective factors as a function of level of consciousness, which they operationalized as this CRSR item on the visual subscore between 0 and 2. And they found that in comatose patients, which was all of these, having 0 or 1 airway protective factor led to only a 38% probability of successful extubation, whereas having 2 or 3 protective factors intact led to an 85% extubation success rate in comatose patients. This rate is comparable to general critically ill patient populations that have passed a spontaneous breathing trial. So very telling that, again, coma on its own may not be prognostically all that important if airway protective factors are intact. Again, this is all speculative still because it's a small single center study, but highlights, I think, an important point, which is that, at least for me, airway protective factors should probably be considered quite strongly in the decision to extubate a brain injured patient, especially among those with a low level of consciousness in whom you're debating whether extubation versus proceeding straight to tracheostomy might be the way to go. So then I'll pivot to this 4th study by Rafael Chinati, who I believe was a speaker in a prior talk in the series. He did a very nice prospective observational study called ENIO that was conducted across 73 ICUs in 18 countries worldwide. And the objective here was several-fold, but the primary one was to create a score predicting extubation outcomes similar to the study by Godad and colleagues shared previously. The outcome was extubation failure as defined as the need for reintubation after extubation attempt. They looked at days 2, 5, and 28. They reported data up to this time point, but built their models mainly for the day 5 time point. So they included just over 1,500 patients, and extubation failure by this day 5 time point occurred in about 20% of patients. And again, their objective was to create a model to predict extubation outcome, which they did using similar lasso procedures to the Godad paper, and they identified 20 variables that were potentially prognostically useful that went into the model. They realized this may be a little bit cumbersome to apply at the bedside, and also therefore presented a simplified model, including only 7 of those variables. So this is the result of the lasso procedure on the full data set, excluding patients who had received primary tracheostomy. And you see here that multiple demographic, comorbidity, and other illness characteristics are well represented, as are many extubation day items, which are everything below the GCS eyes line on this table. So the heart rate, the respiratory rate, temperature, and so forth. So I'll draw your attention to the GCS subscores, eyes, and motor components, which were identified as important by the lasso model. And then also airway protective factors, cough, swallow, gag, all important, as was the endotracheal suctioning frequency. So again, highlighting the theme here that Glasgow Coma Score makes its way into some of these papers, airway protective reflexes certainly as well. So the area under the curve of the full model in the training cohort was 0.79. They then validated this model in the same data set, but in a validation cohort that was separate from the training cohort. and found that the AUC dropped a little bit to 0.71, but was still not too bad. They then presented the results of the simplified model, which again highlights the prognostically useful variables this model retained, which were, again, the theme being here, airway protective reflexes, gag, swallow, cough, and suctioning frequency, and also the GCS motor subcomponent of the overall GCS score. They then presented the AUCs of the simplified model. This was 0.79, so exactly the same as for the full model in the training cohort, but the AUC dropped quite substantially in the validation cohort to 0.65. So there's a lot of very, very nice data in this particular paper, certainly the largest and one of the best in this field. Gives us a lot of useful information that are very relevant to daily clinical decision-making in the ICU. So I almost haven't done it justice by spending only 3 or 4 minutes on it. But the main takeaways, at least for me, for this paper is that a clinical score can be used to suggest patients at high risk of extubation failure, albeit with limited predictive accuracy. You can see, especially in the simplified model, the AUC was only 0.65 in the validation cohort. And this is the model that most of us are likely to remember because it's easier to carry around than the more complex model. Airway factors, regardless of the model chosen, seemed to be important. And at least in the Chinanti paper, GCS subscores may be more prognostically useful than the overall Glasgow coma score, which was also a point made by an editorial that accompanied this article in the original ICM publication. So there's much more literature in this space that I could have potentially talked about. Selected these studies because they are some of the larger ones that are quite illustrative, and I think highlight the themes that predicting extubation failure, especially in brain injured patients, is a formidable task. It's often quite humbling to see a patient in whom you're almost certain the outcome will be one thing and it turns out to be exactly the opposite. And speaking to people who have a lot of experience and who've been working in this domain for much longer than I have, that seems to still be their clinical experience quite often. Airway protective factors are probably important to consider before extubation, and the Glasgow coma score may or may not be important, but the data are inconsistent. You have seen now 2 studies showing that perhaps it's useful and 2 that show that perhaps we can do without it. So the data are, again, inconsistent with respect to that prognostic factor. What the data do not tell us is what GCS thresholds, if any, should be guiding our extubation decisions, and whether post-extubation strategies can modify reintubation risk. So the decision to extubate a patient is not where the game stops. There is a lot that happens after that. And if there are tools that we can implement in the post-extubation period to attenuate a patient's risk for reintubation, then why not leverage some of those tools? And none of the data shared to this point comment specifically on post-extubation strategies, and this will be relevant for a paper I will share in a few slides. And then the data also do not tell us to what degree practice heterogeneity in extubation outcomes exists, for example, across centers or across countries. A lot of really nice data, specifically from the ARDS literature and LungSafe and its associated sub-studies, do a really nice job of quantifying practice heterogeneity and the extent to which that may inform outcomes in different geographic regions worldwide. But there really isn't comparable data in this space in the brain injured patient population. So from that, I will pivot to research that our working group has been conducting in this area. And I'll share first the results of a systematic review that was published earlier this year. And to keep this topical and relevant to the current discussion, I will only share papers in the last year, mainly because they explore some of the evidence gaps brought up by the prior studies. So this first study was a systematic review and meta-analysis of observational studies in one randomized clinical trial published in Critical Care Medicine earlier this year, wherein we were looking at prognostic factors associated with extubation failure in patients with acute brain injury. The question was, what factors are associated with this outcome of interest? We included studies wherein patients were mechanically ventilated for greater than or equal to 24 hours, excluding patients where the duration of invasive ventilation was lower than 24 hours, because we assumed that many of those patients were perioperative patients who were undergoing routine extubation after, we suspected the majority of cases, routine neurosurgery. And the question that we're trying to answer is really more tailored to a slightly different patient population in whom there's a bit more prognostic uncertainty about their chances of succeeding extubation. So again, as mentioned, this was a systematic review and meta-analysis. We included 21 studies. Overall, they provided 3,274 patients. The primary outcome was extubation failure, which we defined as the need for reintubation within 72 hours of the extubation attempt. And in sensitivity analyses, we looked at different time points to see what effect that may have on the outcome. So this is our table 1, including the 21 studies. And you can see this is pretty representative of a neurocritical care unit. Certainly the one in which I work in has a patient breakdown that looks quite similar to this. So traumatic brain injured patients composed about 38% of overall patients. Subarachnoid hemorrhage composed about 16%. Ischemic stroke was 14%. This is spontaneous non-traumatic intracranial hemorrhage from etiologies like amyloid, hypertension, anticoagulation, and so forth. This was 12.5% of the patient population. Patients with brain tumor composed 5%, and everybody else was a minority. These were things like status epilepticus, cranial central nervous system infections, and so forth. The median age in this overall group was 53 years. This was at the study level, not at the individual patient level. This was not an IPDMA. This was a study level meta-analysis. So the median age across studies was 53 years. And extubation failure was seen in 25% of patients, again, similar to that study by Godad and colleagues. So this was our adjusted meta-analysis of prognostic factors, which we had derived primarily from multivariable logistic regression models reported in the original study. And what made these factors adjusted was that they had co-adjusted for at least one other prognostic factor. The caveat here being that not all studies adjusted for the same exact prognostic factor. This is a limitation of prognostic systematic reviews in general, where you do expect to find multiple models adjusted in different ways. Comparability would certainly be enhanced if all of them adjusted for the same factors, but that's just not how this tends to be in the literature. So with that caveat in mind, we looked at multiple factors across studies. To orient you to this odds ratio plot, everything to the right of the vertical line at 1 is an increased association with extubation failure. Everything to the left is a protective or decreased association with the odds of extubation failure. So you can see that older age was associated with increased odds of extubation failure. We looked at all of the continuous variables on this graph using tertile methods, wherein the patients in the highest tertile of the specific factor compared to those in the lowest tertile. When we applied this method to age and duration of mechanical ventilation, we found that those two factors were associated significantly with extubation failure. So the older you are and the longer you're ventilated, the higher the odds of the primary endpoint, which intuitively I would say makes sense. Then we looked at prognostic factors related to airway protection, and we see that cough and swallow are protective in this systematic review. So the odds ratio doesn't is to the left of the one line and doesn't cross the one there. I'll highlight GCS at extubation, which was not significant in this meta-analysis. GCS motor score was not significant if you apply this dichotomous frequentist p-value 0.05 threshold, but you can see that most of the confidence interval is on the line where one might think it's prognostically useful. We then graded the recommendations using standard grade methodology that have adaptations for prognostic factor reviews. And we found that for all of these factors, there was moderate certainty evidence that they were associated with the outcome of interest. And the downgrading from high certainty primarily happened because of concerns about risk of bias. You can see that in all of these studies, there were serious concerns in that specific domain of certainty assessment. We then looked at unadjusted prognostic factors, looking across various domains, including airway, hemodynamics, illness characteristics, and brain injury characteristics. So this is unadjusted data being primarily included from the table ones of studies or from 2x2 tables, which we'd handwritten using data that was presented in the manuscript. This was quite a challenging task. We found that GAG is protective against extubation failure, again, to the left of the odds ratio 1 line. We found that maximal inspiratory pressure and maximal expiratory pressure were protectives. These are often used as reliable surrogates of cough strength. The higher they were, the lower the odds of extubation failure. Whereas none of the hemodynamic and gas exchange factors indicated were significant, although you can see that minute ventilation was, again, the bulk of the confidence interval line was towards the right. And then when we looked at demographic factors, the Apache 2, which is a score for illness severity measured at ICU admission, was significant. So the higher the illness severity, the greater the odds of extubation failure. And then the GCS visual subscore less than 4 also seemed to be associated with this outcome. So again, very important caveat that these are unadjusted factors. It's unclear if the association would persist after adjustment for other variables, but I think highlights some useful information in a domain where evidence is otherwise limited to begin with. We then looked at additional outcomes in the systematic review and looked primarily at the reasons why these patients were being reintubated. And then in ascending order, we found that excessive secretions were the reason for reintubation in a median of 9.7% of studies, decreased level of consciousness in a median of 16%, stridor and respiratory failure, which occurred in 36.4% of patients, which is actually quite interesting and useful to keep in mind because it concords with the data that the ENIO study found, which was that the highest reason for reintubation in that cohort was also respiratory failure, and speaks to the multifactorial etiology of why brain injured patients fail extubation. It's not just for airway protective reflex reasons or GCS. They're certainly entitled to fail for cardiorespiratory reasons, which is the primary reason that your medical ICU population may fail. So all of this to say that these aspects of why brain injured patients may fail should not be neglected as we focus potentially on the airway and the GCS. That aside, we found that ICU mortality was numerically higher in patients failing extubation, as was the intensive care length of stay. We did not look at prognostic factors in relation to each of these outcomes because that wasn't the motivator for this specific study, but I'm sure you could do a similar systematic review and quantify some of those associations. So the summary from this systematic review is that extubation decisions in brain injured patients may be usefully guided by airway protective factors. I will say that a lot of the studies we included, the primary studies were different from the ones that I had shown in the survey of studies at the beginning of this talk. So the data isn't just coming from the Godad study and the Neman study and so on. There were actually many other studies not indicated in the previous part of the talk that made its way into the systematic review. Results, again, were still the same. And the association of Glasgow Coma score with extubation outcome remains very uncertain. So again, we downgraded the level of certainty for multiple reasons, one of which is that in some primary studies, GCS below a certain threshold was actually a reason to hold up somebody's extubation. And if you try to meta-analyze that with a study where that isn't one of the criteria to undergo extubation, there's already some heterogeneity that's starting to form. And so recognizing that heterogeneity, we had to downgrade in multiple domains. And so the prognostic utility of this specific variable, again, remains quite uncertain from the overall literature. Paul Nyquist, who I believe was also a speaker in this previous series, perhaps the first speaker, if I'm not mistaken, in your very nice series, wrote this editorial in Critical Care Medicine, essentially highlighting most of what we've talked about, highlighting further that limitations in this study probably relate to the fact that there aren't very many studies looking at prognostic factors for extubation failure, and therefore doing a meta-analysis is a bit challenging because you're left with very few prognostic variables you can meta-analyze. There were also some nice tips for how we might choose to structure studies in the future, and so we were very thankful to Paul for that nice editorial. So we'll segue now and talk about results from a secondary analysis of ENIO. This is work that was just published a couple of weeks ago in the Blue Journal, the American Journal of Respiratory and Critical Care Medicine, mainly looking at the second part of what I had brought up in the summary slide shared previously, which is what strategies can we employ after extubation to modify patients' reintubation risk? And a couple of strategies that we quite commonly use in medical surgical patients are high flow nasal oxygen or non-invasive positive pressure interfaces. So there isn't, as far as we know, any data in the post-extubation setting in the brain injured population. So we asked the question using the ENIO data in the paper that I will share now. The rationale for this, why we bothered to investigate this, was based partly on the systematic review and meta-analysis published by my colleague Shannon Fernando, who's an intensivist in Toronto. He did a meta-analysis of 36 randomized clinical trials looking at the association between non-invasive ventilation and conventional oxygen. That was association 1, and association 2, high flow oxygen and conventional oxygen, and the odds of extubation failure in both of those comparators. And he found that non-invasive ventilation was protective. The odds ratio was 0.65, so 35% reduction in the endpoint. And high flow nasal cannula was also protective in with a 37% reduction in the odds of reintubation. So it seemed to be protective, but these results were only valid when the modalities were used in a prophylactic context as opposed to in rescue situations. Prophylactic being that the clinician decides before extubation to apply these modalities in advance. Rescue being that the decision to apply these modalities is in response to patient deterioration, whether that be increased work of breathing, respiratory distress, tachypnea, so forth. So again, these associations were protective in the prophylactic context, but not in the rescue context. There was also further evidence of benefit when the risk of reintubation or when the baseline vulnerability of the patient to this endpoint was suspected, again, to be higher. So you can see here, they look at non-invasive ventilation, high flow, and the combination of these modalities separately. And when the risk of reintubation increases, the number needed to treat also decreases. And so these modalities may potentially be more effective when the baseline risk of the patient population is higher. That's relevant to the brain injured population, where we're typically talking about extubation failure rates in the 20 to 30% range, which is higher, again, as mentioned, from your general medical surgical ICU population. So in all three cases here, whether it be for non-invasive ventilation or high flow or the combination of these modalities, the number needed to treat is lowering as the risk of extubation failure is increasing. So with that context in mind, we performed a secondary analysis of the ENIO study. We evaluated high flow and non-invasive ventilation as separate exposures. That is to say, patients could not have received both at the same time. We used mixed effect models, or multi-level models as they're sometimes called, to evaluate the association between main exposures and reintubation. In each of these models, high flow and and non-invasive ventilation were entered as separate covariates and separate classes of models. And we had selected all of the adjustment factors or patient covariates a priori. There was no data-driven selection procedures used here, all based on our causal interpretation of how these pathways are likely to play out. And then in the second part of the study, we looked at Bayesian methods to estimate the clinical probability of equivalence, benefit, and harm from the analysis. The random effect part of the mixed model was as follows. So we had created nested models to reflect that patients are nested within hospitals, hospitals are nested within countries, and that correlation structure to make sure we got it right and to make sure that there was no bias being introduced by incorrect association. We fit in random intercepts for centers and random intercepts for countries. So fixed effects came from patients, one random intercept for the hospital and one random intercept for country. That's how, generally speaking, the models were built. So I did mention at the beginning that I would spend a little bit of time where I thought relevant to talk about statistical principles, and this is a very simple one, but I think is worth a minute of a tangent from this talk, which is that for causal questions where you have an a priori sense or an a priori belief that exposure A is related to outcome B, or you want to test that exposure, then the clinical interpretability of your results is enhanced when covariates are intentionally selected. That is to say that you're not using statistical methods such as backward selection, univariate comparisons to choose a significant covariate, or other selection procedures that you leave up to a computer. That's not to say that those don't have their place. They certainly do for anything that's prognostic, for building models, prediction tools, and so forth. Very much a place for that approach. This is specifically for causal questions where you want to test a priori hypotheses and you have a general idea of what the causal structure might look like. And the reason why this is important is we all are aware that a confounder is a variable that's associated with both the exposure and the outcome, and that does not lie within the causal pathway. So using techniques like adjustment through regression, for example, or stratification, eliminates the effect of the confounder on this association and allows you to determine an unbiased strength of association for this level C here. You have control over that as the builder of the models or as the analyst, but if you leave it up to a computer, it's possible they may select mediators, for example. A mediator is a variable that lies within the causal pathway, and adjusting for this will attenuate the strength of the association that goes through this series of arrows, and you'd be left with C prime here. This may be an attenuated version of the association you actually want to show. So a computer may not know that this is a mediator. A statistical software may identify this as significant and put into your model, and what you're left with is a C prime relationship, whereas what you're trying to estimate is actually C. So and this can be true for mediators. It can be true for variables that are called colliders and so forth. So suffice this to say that you should be pretty intentional about the covariates you put into models when you have a priori causal questions you're trying to investigate. This was the causal diagram for the study that I am currently sharing with you, wherein we plotted out how all of these things could potentially affect both the exposure levels and the outcome levels, and looked at, again, only covariates restricted to this graph. Some of these covariates are vectors for multiple variables, SBT variables, for example. This includes things like heart rate, blood pressure, respiratory rate, and so forth. But I think this just illustrates how we presumed the causal pathway between exposure and outcome might look for this study. And this is also a way of making it transparent for others. If people disagree, then again, there's a transparent way in which that disagreement can occur, as opposed to saying, we built a model, this is what the odds ratio is, and then that transparency is somewhat lost. So that was a statistical segue. Now going back to the results, we included 1,115 patients from 67 ICUs in 18 countries. The median age of this cohort was 54 years. The majority of patients were enrolled from Europe and North America. It was about 90% of the overall patients. The most common admission diagnosis was traumatic brain injury in about 50% of patients. And we noted that high flow nasal cannula or non-invasive positive pressure ventilation were used in about a quarter of the overall cohort, which was somewhat surprising to us. But was also very nice to see. It means that clinicians are in some cases enthusiastic or willing to try this modality, despite the evidence before the study being somewhat limited for that. 233 patients underwent reintubation in the intensive care unit. That worked out to 21%. And the majority of those reintubations were occurring within 5 days of the extubation attempt. So 19% of the reintubations, which were classified as extubation failure, were occurring in that shorter time frame. So this is a flow chart of patient enrollment. We excluded 319 patients with a primary tracheostomy because they were ineligible to experience the outcome of interest. 15 patients had missing reintubation status, and we excluded 63 patients where high flow and non-invasive ventilation interfaces were applied together, either in alternating contexts or in escalation from prophylactic to rescue contexts. And we wanted, because there were too many co-interventions happening in too many different contexts, we wanted to just eliminate that from the analytic models, because there was, again, too much confounding and residual confounding we wouldn't have been able to account for. So this left 1,115 patients, of whom 267 received the support modalities, of whom 105 received prophylactic high flow and 71 received prophylactic non-invasive ventilation. We included these subsets in adjusted models that I will describe in subsequent slides. 91 patients overall, so 60 with high flow and 31 with non-invasive positive pressure ventilation, received these modalities in rescue contexts. And we did not include these in adjusted analyses because we did not have access to post-extubation confounders and time-varying covariates happening after extubation that would have allowed for us to present appropriately adjusted models for these variables. So we only presented unadjusted results for this subset. All of the associations from our models were reported in reference to the 848 patients who were extubated either to room air, nasal prongs, or simple face masks. So all the odds ratios that you're about to see are relative to this reference group. This is our table 1 that makes many of the points that I've already mentioned. So I'll skip through it, mainly to say that, again, median age was about 54 years. Most of these patients were from Europe and North America. So we're looking now at prophylactic high-flow nasal cannula. This is the first exposure and the odds of reintubation. On the left side, we have unadjusted Kaplan-Meier curves looking at conventional oxygen and prophylactic high-flow oxygen. You can see that there's no difference between the two in the unadjusted analysis. Log rank test is not significant. Then we proceeded to fit several adjusted models for this association. The base model was using that mixed model approach that I described a few slides ago, adjusted for patient covariates and random intercepts for hospital and country. And then we applied various sensitivity analyses. This was an analysis looking at inverse probability treatment weighting. Building a propensity-based estimator for the propensity to receive high flow oxygen versus standard oxygen, and then looking at the outcome using that technique. We did an imputation analysis accounting for missing data. We looked at shorter timeframes to extubation failure. So this was reintubation within 5 days. This base model was fitted for reintubation at any point in the ICU. And then we censored patients who had competing risks that would preclude the outcome of interest. All of these models were fitted into a mixed model structure that looked very much like the base model, and they were adjusted for all the same patient covariates, just so that interpretability as we go down is maintained. So all of this to say there was no association in any of the analyses, including with the primary model or any of the sensitivity analyses for high flow oxygen with the odds of reintubation. So all of these point estimates are very close to 1, and the confidence intervals all quite convincingly cross 1 both sides, as highlighted here. Next, we looked at prophylactic non-invasive ventilation, applying the same modeling strategy, albeit in a different class of models adjusted for this specific primary exposure. So in the unadjusted analysis, this is on the left here, Kaplan-Meier curve shows that the odds of reintubation are actually higher with prophylactic non-invasive ventilation compared to conventional oxygen. Log rank test is significant. Again, this is unadjusted, but when you adjust it for all of the factors that we described in the previous causal diagram, and applying the same modeling strategy, you find, again, no difference. But what I think is important to point out is that the point estimates on this side are all towards the protective side. Again, there's not very much you can do with that information. Confidence interval lines still cross 1, but I think this graph looks very different from this graph, I would argue. There's more concordance across the various ways of looking at this data. So in both of these frequentist analyses using standard p-value cutoffs of 0.05 and dichotomous interpretations, there was no association between each of these exposures and the primary outcome. We'll segue that into the next part of this analysis, which was a discussion on Bayesian methods. I'm cognizant of time, so I'll spend only a few minutes on this. The very quick description is that Bayesian methods can help us quantify the clinical probability of efficacy from a treatment, and they can allow us to directly estimate measures that clinicians actually care about. The way they do this, at least in part, is through the integration of existing data into effect estimates. So you quantify your prior beliefs through a prior distribution, which can come from expert opinion, literature review, systematic reviews, and so forth. You fit your data to the data set you have on hand, and you generate a likelihood function as indicated in this light green bell curve. And then the interaction between prior beliefs and evidence fitted to your data set generates this posterior probability distribution, which is the middle green bell curve. So the strength of your priors, as you can see from this very simple graphic representation, can substantially alter where this posterior probability distribution might lie. When we looked at that, I wish I had more time to go into this, but I'll keep it very brief just so we can have questions at the end. When we looked at the high flow nasal cannula, using a data-driven prior from a systematic review by Shannon Fernando, which I had shared earlier, we took the point estimates from that systematic review adjusted the uncertainty to account for uncertainty and applying those effect estimates to a different population, we were left with a 34% probability of benefit. That is to say, 34% probability that high flow nasal oxygen will reduce odds of reintubation compared to conventional oxygen therapy. That's this blue part of the bell curve here. And an 11% probability of harm. So it's likely to increase odds of reintubation compared to standard oxygen, 11%. And this is the region of practical equivalence, this area in light gray, meaning that there's no difference. When we used a skeptical prior, that is to say, we don't think this intervention is going to work, that's our prior belief, and then we applied the likelihood function to our data set. This is the posterior probability distribution that results. Probability of benefit is 17%, and so too is the probability of harm. So in both cases, the probability of benefit is pretty low. The probability of harm also, on the flip side, is pretty low. Non-invasive positive pressure ventilation had a higher probability of benefit, between 46 to 74%, depending on your prior beliefs, and a low probability of harm of only 2 to 5%, which was quite interesting. I'll skip over the rescue results, which were again unadjusted for the sake of time, and highlight briefly that all of the additional outcomes we looked at, including ICU length of stay, mortality, and hospital mortality, were no different between prophylactic exposures and conventional oxygen therapy. All of these odds ratios cross one quite generously. So the summary here is that there was no association between our primary exposures and reintubation risk. The Bayesian analysis demonstrated a moderate chance of clinical benefit, although also important to know that the chance of harm from both exposures was low, and there was no association with any of the other endpoints. So my interpretation of this is that these modalities may not be useful for all patients with primary brain injury, but that average treatment effect at the cohort level may not translate into individual treatment effect at the patient level. So there probably are still patients, including many brain injured patients, who may benefit from these modalities based on your physiologic sense of what the underlying reasons for them likely to fail extubation is. If you think they have hypoxemic respiratory failure, a substantial, very prominent cardiac history or COPD history, then again, there may be a role for these devices, because the fact that they have brain injury doesn't change the fact that they also have underlying vulnerabilities that might properly be addressed by the interventions you're choosing. And you may also be rest assured that there's a low chance of clinical harm from our Bayesian analysis. So when you're calculating risk-benefit trade-offs, at least this part of our analysis may support the decision to try in some cases. All of those points were made in this nice editorial by Alejandro Rubinstein and Romain Paracchio that accompanied the Blue Journal paper, where again, they indicated that there may be evidence of individual patient benefit. I will skip through those last couple slides for the sake of time, and mainly end this talk by saying that this is a really exciting area of research. We do need a lot of data in this space. I think that the last year has been very, very informative in terms of moving the needle and setting some standards for the rest of us to follow when we do research in this study. And I'm referring particularly to the ENIO study by Chinati and colleagues that really set a very high bar for the rest of us. I think there are important implications for clinical practice. Any data that's published in this space is likely to be new and likely to be incorporated into future guidelines and likely to be very relevant, which is the most important thing in my mind for clinician-driven bedside decision-making that has potentially patient-important impacts. And I think the way we achieve all these things is through collaborations between centers, because again, this is a small patient population, it's a small research group, and I think the quality of data emerging from the space may certainly be enhanced when we work together to address those questions. So I'd like to end with some acknowledgements to Aaron Joseph and others for the invitation to speak today, and I'd like to thank the audience in attendance as well for their attention. With that, I think we have a few minutes for